Hi everyone, my name is Shireen. Welcome to this talk on reflective practice. We will kick off with defining what reflective practice is. This is a tool that is used frequently in the field of education, which has gained traction in medical training in recent years. The reflective practice is the process whereby an individual thinks analytically about anything relating to their professional practice with the intention of gaining insight and using the lessons learned to maintain good practice and make improvements where possible. It is thinking about or reflecting on what you do. It is learning from experience, both good and bad. So why should we do it? It is a means to address issues such as diagnostic decision-making, medical errors, cultural competence, professional lapses, and burnout. Reflective practice does not have to be confined to an individual, although that is what we are focusing on today. Individuals, teams, and even organizations can use reflective practice to effect change that results in safer professionals, safer culture, and safer systems, ultimately resulting in better patient care. Many models of reflection are described, which share similar components and processes. All involve a process of looking back on and looking forward, as the reflector identifies a clear focus for reflection, explores it to make personal connections, uses multiple perspectives to make sense of it, and outlines a specific plan for learning or improving one's own mental models, behaviors, and practices. One model is the Shireen model, which categorizes reflection into reflection in action and reflection on action. For example, while teaching a ward round, you think in real time whether or not junior doctors understand your clinical reasoning, taking feedback through verbal and non-verbal communication, and adjusting your teaching style in real time. That is reflection in action at the time that the event is happening. This is reflecting on the experience itself, thinking about it during the event, deciding how to act at the time, and acting immediately. However, reflection on action occurs after the event. It is reflecting on something that has happened, thinking about what you might do differently if it happened again, and using the new information to inform your experience and using it again to process feelings and actions. This is the reflection on action that most of today's talk will focus on. Another model of reflection is the Gibbs reflective cycle. It has a factual description of the event, how it makes you feel, an evaluation and analysis, a conclusion, and an action plan for the future. These are the steps that we will use today to explore the reflective process. Here are some key points on reflection before we begin to explore the process. Reflection is personal, and there is no one way to reflect. A variety of tools are available to support structured thinking that help to focus on the quality of the reflections. Having time to reflect on both positive and negative experiences and being supported to reflect is important for individual well-being and development. Group reflection often leads to ideas or actions that can improve patient care. The healthcare team should discuss openly and honestly what has happened when things go wrong. Reflection should not substitute or override other processes that are necessary to record, escalate, or discuss significant events and serious incidents. This is not a replacement for a root cause analysis, for an incident report, or for a mortality review. When keeping a note, the information should be anonymized as far as possible. Tutors, supervisors, appraisers, and employers should support time and space for individual and group reflection. So what should we reflect on? Any event can be a catalyst for reflection, both events that went well and those that did not go as well. For example, we can look at what went wrong, such as a post-operative complication, a misdiagnosis, a dissatisfied patient, or a failed procedure. We can also look at what went right, a well-managed cardiac arrest, an interesting seminar or conference, a patient thank you letter, or a difficult but well-performed procedure. This is an example of an event that might trigger a reflective process seen from the view of a junior doctor, such as a house officer or a medical officer. I was involved in a patient confrontation. The patient was unhappy with her hospital stay and wanted to be discharged home. Unfortunately, she had to go to a nursing home and so could not be discharged. I explained this and she returned to her bed. I was happy I had explained everything to her and continued with my other jobs. Now, you can see here an example where the reflective process has not been well drawn out. The reflection is a little superficial, it is short on detail, and there is no action plan going forward. Using the previous example, we will now go through each step of the reflective process in a little more detail to explore what each step means and what we can do in a practical manner. So first we start with a description of the event, the facts of the situation, the what, the where, and the who. Remember to keep the description anonymized or de-identified. In many training programs, the trainee is expected to keep a log or a record of their reflections. So it is best to maintain, as much as possible, some anonymity in terms of the patient details revealed. Remember also that you are not writing a medical report, so you do not have to provide a lot of technical information. Going back to the previous example, this is how you might flesh out in a little more detail about the what, the where, and the who. I was involved in a patient confrontation. An elderly patient was unhappy with the hospital stay and wanted to be discharged home. She was under our general surgical team for a head injury and observation after a normal CT brain. She had been seen on a ward round and was told that she was medically fit for discharge but was still waiting confirmation of transport to a nursing home. The issue was raised with me by chance as I was doing other things on the ward. I explained this to her, and although she remained annoyed, I was able to make her understand what the delay was, and she returned to her bedside. She did not seek further clarification that day. We then move on to a description of feelings. How did the event make you feel? What was your emotional state when the event happened? Some of the words you might use would be confused, angry, frustrated, helpless, bullied. Or maybe it was when something went right, so you felt pleased, proud, fulfilled, appreciated. Again, back to our example. How did it make you feel? At the time, I felt rushed and frustrated. I had a lot of other work to be done, and this was distracting from that. She had already been told she was waiting for a nursing home to get back to us. I understood why this was difficult for her, but did not think that I would be able to do anything to help. The next step is an evaluation of the experience. Why did it happen? How do you make sense of the situation? Try to see this from different perspectives. From the perspective of the patient, of the caregiver, and even your colleagues. For example, if a caregiver shouted at you, was it directed at you personally? Or was it just that the event involving you occurred after bad news had been broken regarding a loved relative? There can also be many contributing factors, so try to assess the source of the contributing factors, which are usually people or systems. So human factors may play a role. For example, making mistakes with repeat prescriptions that look similar, or reading a report for a different person with a similar name. Systems can be at fault as well. So for example, an IT failure may result in a delay in retrieving crucial CT scan images. Why did it happen? The morning round was quite rushed, and so our explanation was limited. I can understand from her point of view that this may have meant very little, and so my explanation of what exactly we were doing may have relieved some frustration. Having been waiting up to this point, it is no surprise that she continued to be angry, but may have been accepting of this plan. And then, an analysis of the situation and your conclusion. Could you have done anything differently? When something didn't go well, it can be difficult to separate your natural emotional reaction to the event from a rational point of view. It may be that a critical review shows that your actions were appropriate even if things didn't turn out well. Conversely, where your actions can be corrected, that lesson should be transferred to other situations. So you should also take another message away from this reflection. Are there lessons that you can transfer to other situations? Could you have done anything differently? I think my explanation was very good, and the patient seemed happy with this, although I did not give a rough idea of how long this would take. It may have been useful to have spoken to the sister in charge to ask for what progress had been made to feed back to the patient. Also, I did not ask her whether she was happy with this explanation. I may have been able to satisfy her frustration further by answering a few more questions or even recognize any other issues at home they might need addressing before discharge. Although the information given in the ward round was correct, it was not understandable to the patient. If this had all been quickly clarified in the morning, the patient would have been happy throughout the day and not caused the problem later on. And the final essential step is the personal action plan. What will you do differently in the future, and how will this change your practice? If you encountered a similar situation again, would you do something differently, or would you change something? And if you did change something, what is the reason for the change? Then there is reinforcement. What happens when you put this change into practice? Do you get the outcome that you were looking for? when you decided to change your practice? What will you do differently in the future? I think that the root problem in this situation was our explanation on the morning ward round. Furthermore, I'm not sure how long such issues take to be addressed. To avoid a similar situation in the future, I will speak to the other healthcare professionals on the ward to get a rough idea of how long occupational interventions such as this and other community interventions take to start. This means that when future patients are medically fit for discharge, I can spend a moment in the morning informing them of what needs to be done and how long it might take. Hopefully, this will allow me to address patient concerns early to avoid them becoming an issue when it is too late. Creating a culture for reflection requires time and support. There is no need for a long essay on every negative or positive event, but this process can be used in a variety of ways, including operative outcomes, complications, patient encounters, and interpersonal work dynamics. There should be time and space to reflect with protection from other competing demands and with trusted guidance from mentors who can facilitate this in a constructive way. Thank you very much for listening to me, and I hope you enjoy the rest of the workshop.